So, hello everyone. Assalamu alaikum. Welcome to the 8th session of HIV Awareness, Prevention and Education Project in Pakistan, designed and led by the APPNA-MERIT HIV Committee. This is a brainstorming session, and we are looking forward to getting your ideas and suggestions on how to improve HIV awareness and decrease HIV stigma among the healthcare provider communities using educational and research tools. Our moderator for today's session is Dr. Saima Abbas. Dr. Saima Abbas is an infectious diseases physician in private practice located in Florida, USA. She also manages inpatient infectious diseases, including HIV patients admitted in the hospital. She graduated from Fatma Jinnah Medical College and completed her internal medicine residency and infectious diseases fellowship at University of Toledo, Ohio, USA. I can just tell you she's also overwhelmed with COVID-19 patients in these days. So here you go, Saima Abbas.
Okay, let me share my, thank you. Let me share my screen. Hanji, can you see it?
Yes.
We can. Okay, Assalamu alaikum everyone. Bismillahirrahmanirrahim. I welcome all of you to this 7th webinar in this series on behalf of the APPNA-MERIT HIV Committee. So I will be moderating the initial part of this session, and then Dr. Hamad Ali will be helping me with the moderation of the latter part of the program. So before we begin, I just want to share the format for today. If you, all those, thank you for being here in the audience. If you have any comments, you can put them in the chat box. You can introduce yourselves there. And if you have any question answers, then please put them in the question answer area. Thank you. So the format today is we have two speakers, Dr. Hamad Ali and Dr. Khalida Zaki from the United States. And then after that, we will be doing a brainstorming sessions with our esteemed panelists from Pakistan. So let's begin. So newsflash, and thank you to Soumya Iqtidar for sharing this on our WhatsApp group, I think a couple of weeks ago. So this is a news which tells us why are we all here today. Pakistan's annual use of 800 million injections, world's highest, fuels HIV/AIDS spread. There are about 200,000 HIV cases that we know of, and its key population has passed the epidemic threshold. And health experts say that social stigma associated with the disease is the biggest challenge for those trying to treat HIV patients. One thing I want to say that this is August 24th, 2021 in the Arab news. If we fast forward 10 years, all these patients, if they are untreated, they will die. This is one thing which everyone needs to understand, that we have 10 years to make some interventions, and we already may be too late because this is only the known number of cases and we don't know how much more there is. Okay, so, a couple of weeks ago, we had a very small brainstorming session. Fiza and myself and Dr. Khalida Zaki and Dr. Hamad Ali, we were there, and we basically wanted to know that after the 6 webinars that we did, where do we go from here and what is the next step? So we basically arrived at these 2 key questions. The first one was, what have we learned from these 6 webinars? And the second one was, and thank you to Khalida for this, for she made the title of the next webinar, which we are doing today, how do we improve the quality of care and HIV education in Pakistan? What we also realized is that the second question is incomplete and absolutely impossible to answer without your input and feedback. And that is why we are doing this brainstorming session. So let me go back to question 1. We, from our end, tried to answer this question, and it was such a rich collaboration, mashallah, and it was such a great experience to be a part of this collaboration. Thanks to Fiza and Bushra Jamil, who made it happen and brought all the right people to the conversation. And if anybody wants to learn about HIV, these are rich resource for knowledge and all the challenges which we are facing all over the world. I'm going to introduce our next speaker, Dr. Hamad Ali, who will be presenting our end of the evaluation of these webinars. Dr. Hamad Ali is a medical epidemiologist currently working in the United States. He did his MBBS from King Edward Medical College and his PhD from the University of New South Wales in Australia. For the last decade, he has been working in the field of HIV and sexually transmitted infections. And over the last 6 years, his work has focused on HIV in developing countries. He also had the privilege to be in Larkana in 2019, where he was working as part of the World Health Organization team that investigated and responded to the HIV outbreak in children in Larkana. Thank you, Hamad. Please go ahead.
Thank you, Dr. Sama. I'm going to share my screen. Assalamu alaikum, everyone. So as Dr. Sama mentioned that today I'll be talking about the evaluation that we did for our HIV webinars conducted so far. So an evaluation survey was sent to the attendees of all webinars, and 135 attendees responded to those evaluations. Most responded attended all 6 webinars, with about 70% attending 3 or more webinars. A quarter of the attendees or respondents had an MBBS, while the majority of the rest had advanced degrees, including MCPS, FCPS medicine, and FCPS in other specialties. About half of the respondents have been doing clinical practice for more than 10 years, with another quarter doing clinical practice for 1 to 5 years. Respondents practiced in various settings, including government, hospitals, and private practice. And most respondents, about 62%, had not treated HIV patients before. All respondents, or almost all respondents, agreed that the webinars were successful in increasing awareness, reducing stigma, and creating partnerships. We used a scale of 1 to 10 to ask the next set of questions, with 1 being the least agreeable option and 10 being the most agreeable option. Majority of the respondents agreed that routine HIV testing should happen in all pregnant women, in all patients diagnosed with hepatitis C, and all patients diagnosed with TB. Most respondents also agreed that HIV courses should be made mandatory part of the curriculum in medical colleges. Most agreed that social workers and case managers should be incorporated for the counseling and care of HIV patients at the HIV centers. Once again, most agreed that more awareness should be provided at the GP level about available resources for HIV, including care and medications. Most agreed that more education should be provided in med schools and beyond regarding safe disposal of needles and safe needle usage. And lastly, most respondents once again agreed that there should be more monitoring and auditing of the blood banks for HIV screening purposes. Lastly, as part of the evaluation, we asked participants to provide some feedback, qualitative feedback on the webinars themselves. And this slide presents how some of the feedback that we received and how we incorporated that feedback into our sessions. The first feedback that we received was to do webinars on a non-weekend day or a weekday for that matter. Interestingly, our next webinar is on Wednesday, September 29th at 8:30 p.m. Pakistan time. Another feedback was to include more topics like STDs, hepatitis, and TB. We have already done a session on HIV and hepatitis C and HIV and TB. However, we are hoping to do a session on September 29th, which is going to be focused on STDs with and without HIV. And that will include gonorrhea, chlamydia, and syphilis. Another feedback was to include microbiologists in the webinar. And one of our panelists today, Dr. Jamila Heather, is a microbiologist. And I'll stop there. Happy to answer any questions, but handing over back to Dr. Saima for further presentation.
Thank you, Hamad. I'm going to stop sharing your screen and go back to mine. Okay, so this was some of the encouraging and appreciative comments entered in the evaluation forms. And Dr. Fiza created this word cloud, and it was good that we got such a positive feedback, and it's always good to be appreciated because we are all in this together. Thank you, Hamad. The way I look at your numbers is that we have 130 people who were in the middle of the pandemic, cared enough for this cause to participate and join us. So we have a team to begin with, and may Allah multiply the numbers and guide us all. So I want to go to the next step, which is introducing Dr. Khalida Zaki. But what I did was, because these webinars were such a rich resource of quotes and words of wisdom, I took one quote from Dr. Joseph Garland, and I want to share this today. So in 2014, the UNAIDS came up with this international campaign called 90-90-90. And what they basically said is that in 2014, we are setting 3 targets to be met until 2020. So 90% of all living with HIV will know their HIV status. That was goal 1. Second was 90% of all living with HIV will receive sustained antiretroviral therapy. And then the third one was 90% of all those who are taking their medication will have durable viral suppression or will be undetectable. So that was their goal. And Dr. Garland brought up the point about the 4th 90. And this is his quote from his second webinar. This is what he said. There's also been a lot of talk about sort of the 4th 90, which really is underlying all of these, making sure that people will address the social determinants of health that are keeping people from being able to engage in care and reach that third 90. So using this quote, we want to move forward and introduce our next speaker, Professor Khalida Zaki. She is a PhD in sociology from Michigan State University, a master's in sociology from the University of Baltimore. She did a 2-year training program in population dynamics from renowned Johns Hopkins School of Hygiene and Public Health. As a trained social demographer, she has adopted an interdisciplinary approach in her teaching and research, including her service to the Institute of International Health at Michigan State University. As a Fulbright specialist, she delivered healthcare capacity building programs to higher education faculty in Pakistan. And she's currently engaged in female leadership training in higher education, which is a US-Pakistan collaborative project. So Dr. Khalida, we would love to hear your unique perspective to this. Thank you. If you can share your screen, Dr. Khalida.
Sure. Hello. Sorry about that. Do you see my screen or no?
Yes, we do. You can open the PowerPoint. Yes.
I don't know what happens to the PowerPoint.
It should be at the bottom, if it's open, in the bottom bar. There we go.
I want to go to the beginning of the. Excuse me. Okay, I guess I'm all set now.
Perfect. Go ahead.
Okay, I am sorry and apologize for this technological glitch. Thank you so much, Saima, Fiza, and everyone. I'm really honored to be on this esteemed panel participating in an esteemed association of APPNA-MERIT HIV Committee. And overall, it's a wonderful project and I'm happy to be sharing my views in this. So my goal in today's presentation is that I provide you a framework for thinking, assessing, identifying the linkages, needs in improving the education in HIV program. And I will answer all the questions and concerns towards the end. Every social sciences are integral part of medical sciences, and very few practitioners realize this. Health, illness exist in society, and we all are a part of that society. So there are two subdisciplines in social sciences: sociology of healthcare and medical sociology. So from those two aspects, I will move forward. First, when I say that we all disease exists in society and we exist in society, so we are all a part of that cultural context. So in that cultural context, there is a culture of disease as well. The culture is defined as norms, values, beliefs, and the knowledge people have, the technical know-how, all of those. And there are material aspects to it, and there are non-material aspects to it. The physical environment is non-material aspect, and material is the values, beliefs, and the way we think. So all of those influence our personal beliefs, personal culture, personal value system, and societal value system is encompassing all of those areas for all humans in the society. So humans interaction, our interactions among ourselves, and the way we all perceive the disease and treatment. So that's the whole broader perspective in social sciences and cultural context of Pakistan that we should be thinking about. So the final point on this slide is conception, prevention, and cure. So in the context of medicine, the social behavior, there is an aspects of preventive medicine, and public health programs focus on awareness, and the curative behavior, the medical behavior on curative sides on disease, and drugs that focus on clinical medicine. So with the changing perceptions in modern medicine, science has changed and medicine has changed.
The practices have changed, so have changed the perceptions. There are new diseases and new ways of addressing those, and very few realize that challenges concerning the illness and health from clients, from the patient's perspective and from the service providers' perspectives, which are the physicians and nurses and staff. So they all face a challenge and challenges. So social sciences try to understand and explain how we should move in that kind of context. So social sciences are very important, and they should be very useful in understanding those aspects. So in the context of sociology of healthcare, health is more than physician-patient relations. Hospital is a social organization. It has a structure and a bureaucracy within which the whole medical staff within that organization operate. And then in the social side, in the society, even in the organization, we have class, race, gender, rural, urban setting, politics, economy, religion, all those impact our thinking. In the context of medical sociology, physician-nurse relationships, there is a power structure and hierarchy in that medical health institution. Diseases and treatments are determined and treated on the basis of science and technologies. Of course, they are overlapping, sociology of healthcare and medical sociology, because we are all part of the society. We think in the way the mainstream social norms are, and then we practice those through our behaviors in treating the disease. So in the case of HIV context in Pakistan, I think it is very important that we look at the beliefs, values, and practices, and partnership of social sciences and medicine are very important. So on the one end are healthcare providers, on the other end are recipients, and there is interaction between them. What kind of communication gap, what kind of service providers gaps are within themselves and with the community or the clients they serve. So there are gaps in understanding. So I list all those gaps as knowledge gaps, attitude gaps, practice gap, and I call it CAP. And the CAP gap is where we need to be addressing the stigma and the needs to improvement. And that's how I would like to analyze the needs assessment through this brainstorming session. And from the perspective of the local partners, practitioners in Pakistan on the ground who know the reality of their practice situation, their clinical situation, and their patients' situations. And both feel a kind of barriers that constrains them for providing the best services. So there are different linkages and variables in between that we need to emphasize. So the critical question I am leaving for all of you is medicine a social science? So you can continue thinking about it throughout this panel, but we need to remember that social and physical aspects are very important, and all are part of our social culture and medical practice. So the goal is that we need to develop sensitivities to those barriers, those values from the practitioner side and from the recipient patient side, so that we could provide the competent services to address the HIV. So there are, from both sides, I say there are barriers. So what are the patient's barrier? There is need to identify that. And what are the service providers' barriers that also needs to be discussed through educations. And there could be behavioral or value systems, whatever those gaps are. So Pakistan is a very diverse society, culturally, ethnically, provincially, rural, urban, or wherever that an individual is located in the society, whether irrespective of who you are, your location determines how you think, how you understand and operate that process of the system, which is always continuously changing and transforming. So the goal here is to provide some sort of improvements, reforms in education, in training on the basis of the assessment, and achieve excellence. So where would you start? Clinical setup, community engagement, your own practices, or what you really believe? Can you really put your belief into your behavior, which is practice? What is stopping you from doing that? There are always technological advances, industrial changes happening in the societies. And when I say technical advancements, advancements in medicine, advancement in testing, advancement in treatment, and how the society, the government, the political institutions, the religious institution support them, why the clients are not coming forward to access those services. What are their limitations? Are there just physical limitation, transport, resources, financial limitations, or just unawareness of the disease phenomena, that how terrible consequences it's going to have? Are there pharmaceutical companies stopping those? So all those are the aspects which need to be considered. So improving medical education and capacity building training programs for the students are important. For the colleges of education in Pakistan are important. And assessment based on gap, we will develop the reforms in education. Education can be formal, education can be informal, education can be a community based, and it must be on, sorry about that, in continuing basis. So that is the goal of this effort. That's how I perceive it. And it is for the benefits of the all society. So the awareness, facilities, access, all those to reduce the stigma and to reduce the barriers through those education. So in summarizing for my presentation, the way I perceive it from the patient's point and from the service providers, physicians training's point. And in Pakistan, the problem is that there are a lot of gaps and lot of misunderstanding of interlinkages. Education may not match with your profession, in other words. So if we, in order to create foundations for students who will become the future doctors, future nurses, future service providers, we need to build from undergraduate level and importance of cultural values and what do they really understand by social cultural values. The barriers can continue, the barriers can be new as well. Are they keeping up with all of those concerns? So it could be undergraduate level, graduate students in their curriculum, in their research, and then continuing. So where do you begin? That is for you to start. So once you have developed a setup.
Dr. Zaki, you have 30 seconds to criticize, to finalize.
30 seconds
Thank
to
you.
finalize.
Yes.
Okay. My final point then is that we can, after you plan a project, a smaller scale feasibility study, a clinic or some sort of model, and then establish a training program, education program, and then assess it, evaluate it, and see the outcome so that you could replicate it to other clinics and universities in Pakistan. Thank you so much. I will be happy to answer any questions later. Thank you.
Thank you very much.
Thank you very much, Dr. Khalida Zaki, for your unique perspective. And I am going to take your knowledge, attitude, practice, the gap that you have mentioned, which I think was the heart of your talk. And I'm going to open the brainstorming session to our esteemed panelists. So the way we have decided is that we will begin with our junior panelists and panelists in the internal medicine and family medicine field who we want to bring on the front lines of the HIV epidemic and open some questions to them and then move on to our other panelists and get their opinion as well. So I'm going to share my screen. So this is the question that Dr. Khalida basically has brought up. And so you can use this question or you can use the title of our webinar, which is how to improve the quality of HIV care and education. And you know, the way I see gaps is that these are opportunities for intervention. So any ideas you have, let's begin. So our next speaker, I'm going to invite Dr. Hina Javed. She is an assistant professor in family medicine in the University of Health Sciences in Lahore. Her areas of interest include promoting awareness about primary care needs, training of medical officers for primary care, antibiotic stewardship, injection safety, managing telemedicine center during COVID-19, raising public awareness about chronic diseases through newspaper articles. So Dr. Javed, we would love to hear your thoughts about this.
Thank you very much for the invite and the introduction. I really appreciate it. Giving one of the places in the panelists to the family physicians. And the reason why it is important is because in Pakistan, family medicine or primary healthcare, if we talk of the larger perspective, is not well functioning and well organized. I was going through your talks and one of the questions that was posed was how to improve HIV education in Pakistan and quality of care in Pakistan. For that, you need to have a mandatory, and the emphasis is on the word mandatory, primary health care. The physician who's based in the community, he or she needs that training in order to get the information out of the patient. The consultation skill, which is the first patient-doctor interaction, that has to be right in order to develop a rapport, because these are sensitive topics. If you do not inject the confidence into the primary care physician, forget about the patient, they will not talk about it because it's a social stigma, it's a taboo. So if one out of the two people, the married couple, if one is HIV or say hepatitis B or C positive, then talking about having another partner getting tested is really like you're pushing a boundary, which in some places, deprived areas where literacy rate is low, it's very difficult to get the male partner on board in the consultation. The other thing I would like to talk about is denialism, which is prevalent. And I'm not talking about denialism in the population that is going to receive the care. It's denialism in those sitting in position of responsibility. And I think that is something that needs to be talked about, addressed, focused in whatever ways. One of the reasons why I started writing in the newspaper was to get that spotlight on different topics. in other stakeholders as well, among the other stakeholders. We already know what the hotspots are, where the hotspots are. We have that information, and I'm talking about the government, the provincial and the federal. What's stopping us from acting? I think we need to talk about it. In a recent meetings relating to universal health coverage, where both provincial and federal representatives were present from the government, there was more focus on the testing and treatment of HIV and the hepatitis B and C rather than the prevention. So that was something I had to kind of again push about the prevention. So challenging topics, somebody has to talk about them. And I think it's time when others, you spoke about the Arab news article. It's rather than people telling us what's happening within our country, we need to kind of be very, very honest with ourselves. And this is a serious conversation that has to be taken place. There's a big elephant in the room. We choose not to see it. That's really ironic, I think. So I think, yeah, and speaking up on relevant forums where the stakeholders are, which the policymakers are. So this has to be heard by them, and not only heard, acted upon as well. So I think that's what I wanted to just say based on that. Thank you.
Thank you so much, Dr. Javed, and welcome to our team. You know, we are looking for people who are passionate about this disease and believe me, we all have the same frustrations at different levels, but I hear your pain. I love this mention of the word denialism. I think that is exactly another elephant in the room and at the level of the patients and providers. And I think that is another thing we can talk about, or maybe bring people who can address that. Of course, prevention is cure. I love that point of yours. And then you know better who the relevant forums are. But if you are, writing and you have a voice, then we will, I think these forums are here to bring people like you and to help you, so that your influence actually is translated into practical solutions and action. So thank you for your input. I'm going to go to Dr. Soumya Iqtidar, who is our next speaker. And I think I'll introduce her. Let me share my screen if I haven't. Sorry. Okay, so Dr. Soumya Iqtidar has been a regular member with our previous webinars as well, and is well known to the APPNA-MERIT HIV Committee. She is an associate professor in internal medicine at King Edward Medical University, Lahore, Pakistan, and is a secretary General of the Pakistan Society of Internal Medicine. She's also the chairperson at the Dengue Expert Advisory Group, Punjab. She has numerous publications in indexed journals and has contributed 3 chapters in Kumar and Clark Textbook of Medicine's latest edition. And her areas of interest include cardiometabolic medicine and infectious diseases. And I think she's currently in Chitral. And welcome, Soumya. Thank you for making it.
Thank you very much, Saima. Yes, I am connecting from Chitral. I was just looking for a good internet connectivity so that we have an uninterrupted stream. So can you hear me clearly?
Yes, yes, we can.
Okay. I think the question which was put to Dr. Hina, I think that's a general question for everybody, because we are today brainstorming about how to improve the patient awareness and clinical care and diagnosis of HIV, especially in reference to Pakistani population. So I have few suggestions. I will not make comment of what is going on, but I have few suggestions from some of the work that I have done in dengue and which has been proven to be successful in creating awareness and approach to this disease among healthcare professionals. That is this, that we have designed a modular type of a course for the healthcare professionals, which is mandatory for all physicians who are treating dengue. So I think a similar kind of a model can be applied to HIV, but this involves seriousness of the government and the other organizations who are dealing with this problem, like Punjab AIDS Control Program or National AIDS Control Programs or UNAIDS. So this kind of module which is developed, and then we take group of trainees every month and we teach them for a series of session, and then we have an evaluation. So it's kind of a certified short course which they undergo, and then they have the certificate to deal with these patients. So I think it's a very successful model as far as one of the other important infectious disease, dengue, is concerned. And because I'm looking after that too, so we can apply this kind of a model for HIV/AIDS as well, where we design, and this has, you know, the stamp of all the organizations, provincial, national, international, which are dealing with the AIDS program. The other important thing that we need to do is to inculcate include this in the curriculum of the medical schools. As I was discussing with you, Dr. Saima, earlier, that we only have one lecture on HIV in the whole medicine infectious disease portion for final year and one in third year. So I think this is not sufficient. So just covering in one lecture in which you just give an overview what the disease is like, what are the important investigations, because we know that the number of the cases are increasing with every passing day, and children are affected, pregnant females are affected, prisoners are infected, truck drivers are infected, sexual workers are infected, and even college-going students, because they're sometimes involved in drugs or needle sharing, they are also infected. So this is a problem which is emerging as a big threat to our country and has to be taken seriously. Going forward with the same, as I talk about the college students, since I do clinical practice, I see a lot of infectious disease. A lot of college students come to me with HIV because they are into IV drug abuse, and sometimes they share needles. So I think arranging lectures and awareness seminars in non-medical colleges and universities is also equally important to tell our younger population, our youth, what are the hazards of this, and if they are suspecting of, you know, getting exposed to HIV, where should they go? And the last and the most important part that I wanted to discuss was that when we talk about HIV and treatment, there are hardly any centers in the private sector. We say that you have, so if a patient comes to me in my clinic with an HIV report or with a blood screening report which shows HIV, so I tell him that I'm going to prescribe you the test, but for treatment, you can't come to me because I do not have access to the medication, and you have to go to a government sector notifiable clinic because they will register you and then they will give you the treatment. So because of the stigma and attached to this HIV and AIDS, people are sometimes very reluctant to go and get themselves registered in a public sector hospital HIV clinic. So I think the access of the medication to private sector is also one of the goals that we should work on, because we can set up private sector HIV clinics too, or maybe we should not call them HIV clinic, but an infectious disease clinics with the provision of these medication in these clinics so that people have more access to it. I can share my experience that we hardly know of any antiviral in Pakistan because there are very few that we have here. And most of the antivirals that we practitioners know are used in either HCV or HPV. And when we talk about HIV, none of the pharma companies have ever approached me to tell me that, you know, we have these line of drugs which are used for HIV, because they know they are not available in the market. So I think we need to work on this as well, and research and HIV conferences. I, being the Secretary General of Pakistan Society of Maternal Medicine, whenever I have to design a course or a seminar or any event for the doctors or healthcare professionals, we never miss diabetes, we never miss hypertension, we never miss ischemic heart disease, because we know that they are rising to a very great number. But there is hardly any session on infectious diseases. And when we talk about infectious diseases, for the last 2 years, it's always COVID. So I think HIV must be included in all the internal medicine and infectious disease conferences, and there should be a separate HIV conference. When we talk about infectious disease conference abroad, when I look up for any conference, the first topic of interest or the abstract submission topics that I see, on the top I see HIV. But when I see the list of the topics of interest in Pakistan, there's hardly HIV in the list. So I think we must include this. But the problem is that since I told you that these centers are in the government sector and hardly in the private sector, so the patients are not available for data collection, for research, and for students to take them up for studying. So therefore, the research and the publications and the interest of people is also limited. I think a multidisciplinary approach needs to be adopted to include HIV in the mainstream of medical field, and then do research on, then write papers on it, present it nationally and internationally, and also update the knowledge on regular basis of our healthcare professionals, starting right from our medical students up till the specialists, because I think that this is the neglected area. And I'm sure if you ask many of the healthcare professionals about the antiretroviral therapies, many of them would not be able to answer how to start, when to stop, or how to monitor. So I think a lot of work needs to be done, and this definitely would be very helpful if APPNA-MERIT, which there you have taken a brilliant initiative, and this was a very good webinar series, very well attended, very well appreciated, very well received. I got a very good feedback from the attendees of Pakistan Society of Internal Medicine who were attending, and they asked me to start an infectious disease course. We're running these 2 courses right now, one for diabetes and hypertension, and third is atherosclerosis cardiovascular disease prevention that we are starting next month. So they actually asked me if we will be starting an infectious disease course, and I thought that maybe after this session ends, we will work on it along with some organizations and come up with a course. And I will just end here by saying that I'm very glad to see 2 of my class fellows in the panelists as well, Dr. Hamad and Danish. Both we are class fellows from King Edward Medical University, so it's kind of a virtual reunion for us as well. Thank you very much.
Thank you so much, Soumya, for excellent suggestions and ideas. And what I loved is that you've already modeled it for dengue, so you can take that model and you know how to get it done. So thank you for your suggestions, and we have definitely noted them down, and I will ask the following speakers and take these ideas to them as well. Thank you so much for participating. I know you're on vacation, but thank you. Okay, so our next, let me share my screen. Our next attendee and panelist is Dr. Jamila Haider. We welcome our first microbiologist to this conversation. She is a lecturer in microbiology, and she is at the Shahid Benazir Bhutto Women University in Peshawar. She recently completed her PhD with a focus on exploring different characteristics of HIV-1 on molecular level in Khyber Pakhtunkhwa in Pakistan. And she is an academic faculty member from the last 8 years at the Shahid Benazir Bhutto Women University, Peshawar, where she leads different annual educational programs, including HIV awareness. Her first-hand in-depth experience on HIV at genomic level in Pakistan is an invaluable resource in the field of HIV in Pakistan. So Dr. Haider, we would love to hear what are your challenges, especially keeping in mind the knowledge, attitudes, and practice gaps that Dr. Khalida had mentioned. So please go ahead. I think you'll have to unmute yourself.
Sorry.
We can hear you.
Thank you, Dr. Saima, Dr. Fiza, and all of the team for giving me this honor and to talk in this forum and be a part of such a great team. I work basically on HIV, and the focus was on the people of Khyber Pakhtunkhwa. That is the third most affected region of Pakistan after Sindh and Punjab. I faced different problems during my study, starting from the lack of the resources to discouragement and psychological issues. I will start with the first problem that exists in our community, and that is we are afraid of HIV. That fear does not exist only in the uneducated people, but even in the educated communities like doctors, our paramedical staffs, our researchers are afraid of the name of HIV. If you are saying, I am working on HIV, everyone will discourage you and will say, are you mad? Would you want to infect you? That was the questions that I heard many times, and that was the comments. So this negative approach gives me a negative energy throughout my work. I was discouraged many times. I was convinced to change this work, to do not carry out the work on the HIV. Ultimately, I got psychologically upset as well. I still remembered that during my study, I stopped working, stopped visit the labs for approximately 5 months. And I couldn't sleep during this whole duration, because all the time I have that thinking that I maybe get infected with HIV. I repeatedly did my rapid test as well to check my status. So this discouragement and fear was with me till the end of my study. The second thing is that the problem that the researchers are faced on HIV in Pakistan is that, that the social stigma and the discrimination attached with the HIV. People do not easily disclose their status of being HIV positivity. And even I observed a few couples that the husband was infected, and as a result, wife got infected, but she was kept unaware of her status and was expected as well. In some cases, the people even, yes, she was unaware of her status as well and was expected. In some cases, the people treat the HIV patient as an exceptional case or a disease, kept them in isolation, and they even do not contact them and buried each and everything that are in the contact of these patients. So in this scenario, it was very difficult for me to get access to the HIV positive patients. After many efforts, I was allowed to talk to these patients, to take interview and collect the blood samples for my research. But after this permission, even the people were hesitated in giving their past history, especially the extramarital status and the being working as a sex worker. Would you believe only one male sex worker and only one transgender I observed during my whole study? In fact, if we observe in KPK, there is a large number of female sex workers and the transgenders that are this community is rapidly growing in Khyber Pakhtunkhwa. So I believe that the number may be much more than what we are seeing and what the media is showing to us. The figures may be much more than that. There's need of awareness and screening programs, especially for these communities. The third problem that is facing on HIV research is that I need a bench area for the work. Basically, I was working on the molecular level, so I need to process my samples for the PCR and for the sequencing, etc. There is no lab that is specifically designed for HIV research in Khyber Pakhtunkhwa, and also because of the associated fear and the stigma, the other research labs do not allow easily to work or on HIV in their labs. From most of the labs, research labs, I got the comments that get out, shut up, and are you mad? Do you want to infect us? This is quite risky, and stop working. Although I do my self-counseling, and I still continue with the work on the HIV, although it was very difficult for me to work in 3 to 4 different labs that were located in different areas of Khyber Pakhtunkhwa. And I have to move daily to 3 to 4 different labs to process my sample. That was quite hectic and difficult. Also, there is a lack of resources for the work on the HIV and a lack of expertise as well. As still the people are thinking that the HIV is restricted to a certain communities only. But in reality, if we see, and what I observed and what I reported in my study, that it is spill over into general population as well. Not only the driver, the IDUs and the sex workers are the infected one, and the migrants people, also a farmer can be infected. Also a medical technician was infected. Also a businessman and people belonging to other occupation were infected. So it means that the infection is not restricted in the different epidemic groups that were reported earlier. It is spill over into the general population. So there are so many other factors and problems that I faced. I share some of them because of shortage of time as well. I keep it in mind that as well. But I will strongly suggest some of, I would like to give some of the suggestions to encourage the young researchers to work on HIV, because this is the need of today. The HIV epidemic is growing rapidly, although we are ignoring this. And although it is the reported figures are not the actual picture of the HIV. Except a few epidemics reported from the Sindh and the Karachi area, there are other epidemics as well all over the country that were not reported. So there is a need to work on the HIV. And to improve this research for HIV, the first thing is just to minimize the fear of the people regarding HIV, whether that is in the general community, whether that is in your practitioners, whether that is in your research community. You have to minimize the fear. You have to make them believe that it is not something in the air that will caught you and you will get infected. People think that in Pakistan, when I was doing my study, people think that you will get infected even if you sit with an HIV positive patient, talk to them or shake hands, etc. And if handling of the samples is a big deal in Pakistan of HIV infected patients. So first of all, we should minimize this fear and should aware the people, even in the, as I already said, in the research community, the mode of transmission of HIV should be cleared, that this is not the way HIV is transmitted to you. This is by some other ways, which is include the body fluids, etc. Transmission of body fluids from the infected to an uninfected person. So the first thing, if you minimize the fear, the young researchers will be involved in the HIV research. Secondly, I think that the problem is not highlighted that much as it exists. As I already said, only few studies are conducted on HIV and only few epidemics are reported from the Sindh. So if the problem is highlighted by the government, the young researchers will be motivated towards this area and they will start working on that area. So the problem should be highlighted and the risk should be minimized. The second thing, we can give by safety and risk management training to the young researchers for the HIV that will make them confident and they will motivated to work on this virus. The other thing we can do is to design, this is a need to design special labs for HIV because in Khyber Pakhtunkhwa, no lab allow you to work for the HIV. And even they are themselves not working on the HIV as well. So there is a need to design special labs for HIV research to facilitate the students. Screening programs should be conducted at different levels. So this will again minimize the fear and the stigma associated with this virus. This awareness and screening should be done at, I think, at schools, colleges, and university level as well. Because in my study, I observed many of the infected cases are students as well. So this screening and awareness program should be conducted in the different communities. The different funding agencies can play a role in this. The different NGOs can play a role in this regard, and they can, as you know, that the financial problem is always there while conducting research. So if they provide some funding, especially for the HIV research, that will also enhance the research culture for HIV in Pakistan. Also, the access to the patient should be made easy. As I experienced that it was quite difficult for me, and I have to take several approvals for this purpose. So this access should be made easy. These patients are registered with different NGOs and with the government sectors hospitals. So these hospitals and these NGOs should easily allow the researchers to talk to these HIV positive patients. They kept the data, even the prevalence data, confidential. I think it is wrong. You should bring the true picture of HIV in front of the people. So they should know that this is a problem existing and we have to cope with this problem. Another thing, the collaboration with researchers that I emphasize, that the collaboration with researchers that have an expertise on HIV, especially people like you in this forum, that will also enhance the, encourage the students and the young researchers to be a part of HIV. Last but not the least, the mentors and the supervisors play a crucial role in this regard. They should encourage the students to work on the HIV. They should do not motivate the students, do not discourage the students. I know it's risky, but it's not that much risky that we should not work on it. Thank you so much.
I think I'm going to give you a big virtual hug, and I feel your pain, and I am so proud of you for navigating so many challenges, and Jazakallah for persisting with your with your PhD despite everything that you went through. So APPNA-MERIT HIV is very big on research, and we and Fiza is witness that we are really encouraging a lot of research, and you have brought up some very heartfelt and important points which have been mentioned by other speakers as well, but we will definitely take all your points into consideration and try our best to take this forward. Thank you so much for your comments, okay, and suggestions. Thank you. So I'm going to go on to our next speaker. Dr. Rubina Nasli. So Dr. Rubina Nasli is at the Institute of Basic Medical Sciences. She's also from Khyber Medical University, Peshawar. She is an OBGYN physician and teaching faculty member at Khyber Medical University and an active researcher with many publications and research projects. She advises many PhD students and junior faculty in clinical biochemistry, nutrition, and basic research. She also oversees work on breast cancer at the molecular level. Her special interest is in women's health. In addition, she is a reviewer of various journals and member of different academic and research bodies. Dr. Nasli, thank you for being here, and we would love to hear your challenges and your suggestions on this topic. Is Dr. Nasli here?
I can't see her in the panelists. I don't think she's
here
here.
in the first stages.
I think she was here till a couple of minutes ago, so she may be having internet connections. Maybe we can move to our next panelist and come back.
Yeah, sure. Let's do that.
I think she's here again.
She is here?
Yes, yes.
Okay.
So Saima, can you ask your question again? Maybe she didn't hear that.
Sure. Dr. Nasli? Let's see if she can acknowledge that she's here, then we'll. Assalamu alaikum. If you can increase your volume.
Assalamu alaikum, everyone.
Assalamu alaikum, Dr. Nasli. Thank you. I just introduced you to the audience, and I just wanted to ask you, we've had a very low. Assalamu alaikum. Can you hear us?
Yes, I can hear you. You people hear me?
Yes, we can hear you, Dr. Nasli. Thank you for being here.
Assalamu alaikum to everyone.
Assalamu alaikum. We wanted to ask you about your ideas about the conversation, what your challenges and suggestions were. And because you deal with the women, we have had one pressing question about antenatal testing in pregnant women for HIV, and we would especially like you to discuss what are your challenges and how do you see if that was mandated. What do you think about that idea?
Thank you very much, but I will share my suggestions that actually I have got two parts of my careers. That one is as a gynecologist and the second is as a basic researcher. Because I have done my specialization in gyne-ops, and then I have done my PhD in biochemistry and started the basic research. So I got the background of this gynae ops, and also now I'm nowadays working as a basic researcher. Yes, there is a need of antenatal screening, not only the antenatal screening of the gynae ops patients, but also the screening of the patients who are coming to the OPDs, the outpatient departments, and who are admitting in the gynae ops unit. Because there is nothing I have asked from my colleagues who are professors at the tertiary care hospitals in this Khyber Pakhtunkhwa at very high post, but they're still saying that there is nothing about the screening of the HIV/AIDS control, the HIV screening test. I remember when I was working in a gynae OPD, a woman, I will share some story with you that a woman was coming for her this gynecological, coming with gynecological problem, and then we were assessing her at that time, and we were also doing her vaginal examination so many times. But after 1 year, we came to know that she is HIV positive, and her husband is was in Dubai, and he was deported from them. But the woman, she never told us that she is HIV positive or her husband is deported from the Dubai because of the this HIV. And so we were thinking that unintentionally, how much people we by ourselves are contaminating the patients, and we are inserting the infections unintentionally at OPD level, at the antenatal level, and at the examination levels. But here now, what is only we do it at a very small level nowadays, and that is at the Hyderabad Medical Complex. There is a separate unit for the HIV patients, that is Family Health Center. And this is in collaboration with the UNICEF and this HIV/AIDS control program. Now here is now the protocol. If some patients are diagnosed with the HIV, the pregnant ladies who are diagnosed with HIV during the somewhere from the periphery or from the other parts of the KPK, they are referred to this family health center, and there they then give them the treatment, and also do the vaginal deliveries or the cesarean sections. And they have on their panel some physicians, some child specialists, and some neonatologists, and also some obstetric gynecologists at their panel who deal with these sort of the patients. But the number of the cases who we are dealing at these family health centers are not the true statistics of the KP population, because most of the people, as I told you about this, most of the people, they are HIV positive, they are in among us, but we don't know about them. Nowadays, I am in basic research, and if I repeat my words, my words will be repetition of Jamila Haider words, because I was a co-supervisor of Jamila Haider, and we started this basic research in the HIV/AIDS. And at that time, one of my senior colleagues, he told me that is gun mein haath mat dalo. और हम इसको he was not in favor to allow us to work in our laboratory of the Khyber Medical University, but on his part, that was because we in Khyber Medical University have not got any such type of the labs which are BSL 4 level, and we can do the basic research of the HIV patient in there. So there are very much difficulties. Jamila Haider told you in a very better way that what difficulties we face in our basic research side, that even our colleagues do not want us to touch the HIV patients, and especially the handling of the blood samples and the laboratories and this and that. So what we need is to, yes, your question is that antenatal screening, that is very much important. HIV/AIDS control program, people should come forward. But I see that there is only one HIV day which is celebrated everywhere. It's also celebrated in Peshawar, and this time they also had some seminar type HIV day in Khyber Medical University. But this is not enough. The thing is not only the words, but the implementation of the words. How to implement these guidelines, in our tertiary care hospitals, secondary care hospitals, and at the primary health levels, where the people even don't know about the HIV screening. So what we need is the education of these healthcare workers, starting from the DAI, the midwives, the midwives, starting from them, the lady health workers, and then the nursing level, then the practitioner, and then gynae-obs physician. There are different level of these medical people. So their HIV/AIDS control program should also arrange some sort of seminars and some sort of workshops, and also to these people at different times and in different levels, so that in different languages, so that they can understand it. And we should also make a chapter or part of a chapter of HIV even at the school level. At the school level and at the college level, at the BS level, we should include it in our curriculum so that the children, they know about the HIV. Yes, they know about the HIV. There is something written in the books, but they just know that HIV is a disease. And here is a myth that the people who indulge themselves in some adult, they are involved in this type of the disease, and then they don't care for them, and they try to avoid themselves from them. So it's all we need in the KPK, which is a war-hidden area, which is a populated area, uneducated area, and also a burden of Afghan refugees is here. So all these are the things Jamila elaborated it in a sequence in a very good way. And I think these all should be the HIV/AIDS control program should address all these things. Thank you so much.
Thank you very much, Dr. Nasli, for bringing a very important point. We do have to protect our healthcare workers with the right kind of equipment and infection control training and practices, so that if you are helping on the front lines of this disease, you yourselves are protected first and foremost. And I think that's where all the fear also springs from. So your point is well taken, and thank you for sharing your suggestions with us. I'm going to share my screen and go on to our next speaker. Dr. Shahzad Ali Khan. Dr. Shahzad Ali Khan is the Vice Chancellor of the Health Services Academy in Islamabad, Pakistan. And it is impossible to put all his accomplishments, achievements, and expertise on one page. But in a few minutes, I tried to pick out what I think was pertinent for our conversation. So what is unique about his CV that I noticed was that he's one of the few physicians who has a PhD in management sciences in Pakistan, and public health as well as finance. And he is well acclaimed and has been to the, he's the fellowship through distinction from Faculty of Public Health of Royal College of Physicians and Surgeons in the UK, as well as Fellowship of Royal Society of Public Health in London. Vast teaching and research experience in health financing and health economics, as well as health system analysis, health management, policy planning, strategic planning, governance, human resource development, well-renowned with 130 peer-reviewed publications, and has worked for several national and international organizations and has secured grants from World Bank, the World Health Organization, USAID, UNICEF, and there was a long list of more global organizations that he has worked with. So truly somebody who has both local and national and international area of expertise, and is mashallah in a position that he can influence effective change. So we are so happy to have you here, Dr. Shehzad Ali Khan, and we would love to hear what your suggestions and wisdom is, and please go ahead.
Thank you. Thank you, Dr. Saima, and thank you, Fiza, for asking me to actually share some of the experiences. Can you hear me clearly? Okay, so let me first, I think, point out that in Pakistan, the biggest need nowadays is to recognize that although there is a long list of key population when it comes to HIV/AIDS, and we include sex workers in it, we call them men having sex with men, hijra sex workers, commercial sex workers, and injection drug users. But last 10 years, you must have noted that there is a huge increase in the prevalence and incidence of HIV and AIDS in Pakistan, almost 100% increase since 2010. I was part of last 10 years, some of the assignments on, you can see the IBBS, the Integrated Biological and Behavioral Surveillance. I was part of the Global Fund grant development. For the last 2 grants, I was consultant for development of the grant. Saima, आवाज आ रही है? आपका mic mute है.
Yes, we can hear you.
Okay.
We can't see you.
Oh, okay. So I think the signal is too poor. So I thought instead of you may not be even listening to me. So this is something which you should understand, that for the last 10 years, the most of this epidemic has changed from a sex worker to syringes. So it's like one S going into another S. So you can see the Ratodero example, you can see the Mandi Baudin and Gujarat and Faisalabad, and you repeatedly, it has told us that it is not the community behavior, it is the behavior of the doctor, the GP, and most of the people who are not governed properly. We call them quacks, but I think I have seen many doctors who are even worse than quacks. So just to make money, to save 10 rupees on a syringe, they are reusing the syringes, they are reusing the IV cannulas. Nobody is getting screening for delivery or surgical procedure. There are aseptic techniques. So I feel that the last 10 years, the proportion of HIV and AIDS in Pakistan is not driven by sex worker. It is driven by most of the healthcare workers. It is the healthcare facility who is at fault, except for some private facilities in all the districts. Some very good private sector facilities. People think in Pakistan then when they go to a private sector facility, they get a quality care. No, only a few private sector facilities provide quality care. They are famous, they are renowned, they have some processes. Majority of the private sector is for profit, and they don't think even twice before reusing the equipment, reusing the syringes, and reusing the. And I have seen fellows, I have seen post holders of the clinical associations. I have seen them doing this sad state of affairs. You go to a dentist, you are never sure, and we have asked people to take their own disposable kit whenever they are going to a dentist. Same is with the most of the healthcare workers. So I think what this Jamila Heather and Bushra and many other colleagues, they have mentioned the stories. I think this is something which is one of the component. Yes, the key population is here, but biggest crime which is being done in the name of HIV, and not just HIV, it is hepatitis C and hepatitis B. Just imagine hepatitis C going up to 9.7% in Punjab. Just 10% of the Punjab population of 110 million. Can you imagine this is through sex? No, it cannot be just by sexual behavior. We are not that kind of a nation in which we are so much, you can say promiscuity is so much that 10% people get it. No, it is the highest intake of syringes per person per year in the world. Millions of injections per year people take. They don't think twice. They think that only this tika or syringe or injection will cure them. KPK is like this, Punjab is like this, rural Sindh is like this. People make money through drips and they use the IV drip center. So I just wanted to highlight, although the topic is different now today, but I wanted to highlight that we should start talking about HIV/AIDS as an iatrogenic problem, not as a community misbehavior problem, not as a sexual problem. So whenever you are trying to develop a course, tell the doctor that you will be responsible for spreading hepatitis C, hepatitis B, and HIV. It is not that poor commercial sex worker or a man having sex with men or a hijra sex worker or a transgender who is compelled maybe sometime in a month on a sexual intercourse. He or she is not more culprit than somebody who is actually doing a lot of sort of reuse of syringes, drip sets, and unsafe equipments, and all kind of scalpels and other things. And I think this is something which in the education should be built in. And it's not just education. To me, the solution is within our health system. We don't need much of the funding to improve the governance of these private sector and public sector providers. What funds you need? You have a DHO, you have a CEO, you have a drug inspector, you have a public health specialist. So there are too many people who are there in the district, and no one cares about this aspect of infection sort of spread through health facilities. We in Islamabad, there was recently a healthcare commission was established in Islamabad, although it was established a few years ago, but it was, you can see, made functional a few months ago. And I'm a member of their technical committee. Look at this number of providers just in one city of Islamabad, 1,482 providers, and only 500 could be reached through some licensing and registration process. The remaining were either quacks or something like that. If the thing is in Islamabad, the things is like this, and Islamabad has a good authority is trying hard to get all of them on board and then train them. You don't have a data on the private sector provider in Pakistan because they are in every hook and corner. You need a license to sell cigarette in here, but you don't need a license to open a slaughterhouse like this, a surgical center or a medical center in the name of any surgeon or physician. So the problem is that majority of the cases, if HIV and hepatitis B and C, they are not through and what the community thinks is whenever you get diagnosed with HIV or hepatitis, they will label you as a bad man, like Jamila mentioned and many other mentioned. वो कहेंगे जी इसने तो गलत काम किया था. Ratodero, you may not know what happened later on. The women were hanged when they got diagnosed with this HIV status, because the people thought they are not straight, they are not right. So the newborns, the infants got HIV, men got HIV, and all of them got HIV through a healthcare provider. Look at this. So I think the main focus of our future infection prevention and control should be making the person inside the facility responsible. Forget about their training, forget about their practice, forget about their knowledge. They are doctors, they are dispensers, they are technicians. They should be knowing this, and they should be held responsible for such practices. So the most important thing will be all the family physicians, all the GPs, all the quacks, and anyone else, if they are found doing such kind of a, like I will say, a heinous crime. You know, a poor girl goes just for a dental, sort of treatment or anything, and she comes back with an HIV or hepatitis C. What will the parents and family think? So the common notion in this country, whenever you listen to the word Kala Yarkan and HIV, they label you as a bad person, as bad as in sex, which is absolutely okay. It is correct, yes. we have around 800,000 plus MSM. We have 228 or 230,000 commercial sex workers. We have around, I think, 52,000 or 60,000 Hijra sex workers. We have around 200,000 plus, I think 120,000 injection drug users. Yes, they are there. But look at the number. The number is 2 lakh, 1.5 lakh, 50,000 startup. Look at the healthcare workers in each city. Lakhon mein ye majood hain, or majority of them are not governed, majority of them are not monitored. So what difficulty is it? I think we should train the medical graduate how to keep record of injections. So number of injections should equal the number of syringes. Very simple. So in the hospital, what is the difficulty in identifying that somebody reused the syringe? And when you go back, you can check the staff or the technician or anyone leaving out of the hospital that whether he or she is taking some syringes at home or IV cannulas or other things. And I did that. I was an MS of a hospital and I did that, and I found a lot of syringes, a lot of scalpels and sharps, other things, because they reused it, and then they saved it for their evening clinic, and they may be using it multiple times over there. So I think when it comes to HIV and AIDS, and when it comes to hepatitis, running behind and shouting against these Hijra sex workers or commercial sex workers, they are poor, very, very marginalized and underprivileged people. They do these things because of multiple reasons. You know that, and we know that. It's around the world. But in this country, the way we are running after them just by using the name of HIV and AIDS and making them look culprit. Not all of them will be transmitting, but majority of the iatrogenic causes are preventable. They are more than easily approachable. If the governance is improved, if the education is improved, if the people are taught that there is a law in this country which can make you, you know what happened after Atodero? No one knows what happened. Who infected them, what was there, whether he or she got some sentence or what, I don't know. But it is not just one. There are multiple, and we always find out on a daily basis that somebody got hepatitis C and somebody got, when our workers are going to...
Dr. Khan, sorry for interrupting, but we are just running out of time. So
yeah, I'm concluding.
Finish in 1 minute. Thank you.
Yeah, I'll share the screen that we have one. In 2016, we developed a handbook for parliamentarians, but this can be used for anyone who needs lobbying, and this can be updated regularly. So the name of the book is HIV Handbook for Pakistani Parliamentarians, and we did some trainings over there of the Pakistani Parliament. But because we thought the most important thing is that the lack of political will. So lack of political will was the main reason. So we had this UNAIDS book. I'll share it with Fiza, and I think I'll give it to Waleed and Shahid and all of the APPNA colleagues. There is one which is, there is a poster as well. I'll show you. This is the book, and then this is the poster. So you can always sort of get this lot of disseminated, and it is available with UNAIDS, and it is not a, you can say, it's in public domain. It's easily available, and these are the things which we actually did. And then something like we can use these for all kind of trainings. When it comes to training, we all of us university people, they can have a certification, like we talked about infection prevention and control certification, and then there is a diploma, and then there is a higher level infectious disease fellowships and other things. I agree with Somya. Already Pakistan Society of Internal Medicine doing a lot. No need of reinventing the wheel. Make partnerships with UHS, with King Edward University, with HSA. We are there. If you want to do any sort of training, I support Health Services Academy's contribution. I will be pro bono working with APPNA, and we will be, and I think we have an MOU with PSIM as well, Somya and Professor Javed. So from my side, I think you can have all this support for training at all levels, not just at the doctor level, even at the lady health worker level. We have all the data and all the linkages in all the provinces. Thank you very much.
Thank you very much, Dr. Shehzad. I think you bring a very important point, which is to change the perception of HIV from a sexually transmitted disease to one which is caused because of unsafe injection practices. So my last speaker is going to be Dr. Bushra Jamil, who will be at the tail end of this talk. And I'm sorry, Bushra, but I wanted everything to happen and all the points to come in before we come to you for solutions and ideas. So Dr. Bushra Jamil is well known to everyone. She's been with us from day one. She's the National Coordinator of Common Unit for Management of HIV, TB, Malaria Grants, and Ministry of National Health Services Regulation and Coordination in Pakistan. She's also President of Medical Microbiology and Infectious Disease Society of Pakistan, and she's a consultant infectious disease at Aga Khan University. Yes, Bushra, go ahead.
So I have comments which are relevant to all the speakers. So Somia first, I guess. So we do have an infectious diseases society in Pakistan, that's MMIDSP, and we do offer courses and teaching and training sessions on an ongoing basis, and telementoring is our latest edition. So if you intend to launch any ID course, please do so in collaboration with us, because this is the Society of Infectious Diseases and Medical Microbiology. Second, regarding engagement of private setup in HIV care, yes, we do have a model, because at AKU, we started this public-private partnership with TB and HIV programs, and it is running very well. So there is no stigma, and patients come to an undifferentiated clinic. There is no way to label or identify a patient except by the physician and the nurse assigned to him. So no stigma, no additional identification, and the center is running very well. So there is an example to follow. There is a model already existing. To me, the most important problem we are facing, and because of which we have not been able to actually resolve any of the issues which have been identified for over 15 years now. It's that whatever we are talking about now is the same which we were discussing 15 years ago. Is the total disconnect between what is happening at the ground, what the physicians are facing, and between policymakers and funding agencies. So it's easy to say that you can divert funds to do this and that, but look at who is funding your programs. If your control program is being funded by a particular agency, they have their own requirements. And then you have to consider who is engaging with those agencies and what are the problems which are being identified and put forward as the issues which need to be addressed. So whatever we are discussing here hardly finds a place in the discussions which take place between the programs and the funding agencies. So at the moment, this has been realized by everyone. So even the funding agencies are very worried now as to what is going on and why have we not pinpointed the problem, and why we have actually failed absolutely in controlling or holding down this epidemic of HIV in Pakistan. So we have to take care of this disconnect. Once we address this disconnect, all the rest of the strategies which everyone has suggested should go on in parallel. So it's not one after the other. Awareness, public awareness, awareness amongst key population, awareness amongst physicians, inclusion of HIV in undergraduate curriculum, inclusion in postgraduate curriculum, ongoing teaching, training, all this has to go on at the same time and engage more and more family physicians and so on. And that's why Hina is here today. So a lot of strategies should be initiated at the same time, but we must address this disconnect between the ground reality and policymakers and the funding agencies.
Thank you so much, Bushra. I think at the grassroots level, that's what you're saying, at the ground realities, we would like those people to come to the conversation as well, you know, with those who are running the ART centers, and what are their challenges, and then what whoever is funding them, which I'm sure you can understand those challenges better than any of us. That, but we have
one other issue, one more point. Actually, people are being made to run these ART centers. They're not doing it because they like their job. That adds to the problem. So you're forcing people to be engaged in a kind of clinical service in which they are not interested at all. So you have to have a workforce which is motivated, who is knowledgeable and knows what they are delivering.
Yeah, I think medical students, don't you think, would be a good resource to start investing in?
They have to be engaged, but again, I think there are very few medical students who want to take up infectious diseases as a specialty and who would like to go on into the HIV side of it. You will find a few people, but everyone should be trained, but you need to have very dedicated individuals to run these HIV centers. You cannot just ask anyone to go and sit there and start running a clinic.
Okay, thank you, Bushra. I hope that we can bring more people who are dedicated and committed, especially everyone here seems to be. So thank you very much, everyone. I think I'm going to hand over to Hamad. Do we have time for questions, Fiza?
I think we can take a few questions.
Okay.
And anyone who wants to leave can leave. And I think we can take like 3-4 questions.
Okay, go ahead, Hamad.
Good.
Sure. So I do see that we have a few questions in our Q&A box, but if you have any other questions, please feel free to add them there, and I will read out some of the questions and hopefully open them up for our panel to discuss. Before I go to the questions that we have in our Q&A, one thing that has come up by pretty much all the panelists is the lack of understanding of the true burden of disease in Pakistan. And I wrote down some of the things as different panelists were talking. So for example, we talked about denialism, we talked about spilling of HIV from key populations to general population. We talked about testing among pregnant women. We talked about different outbreaks over different periods of time across our country. So I think I'll open with the first question, which is going to be, how do we improve or increase our understanding of the true burden? What should we do to get a better understanding of what is the true prevalence or true burden of HIV in Pakistan?
Hamad, do you want to forward this question to any one of the panelists? So we'll have like short response.
Thank you. Can I respond to this?
Sure, please go ahead.
There are two types of approaches which we use in HIV in Pakistan. One is this integrated biological and behavioral surveillance, IBBS. So we have a multiple rounds conducted. The last round was conducted in 2017-18 through University of Manitoba and Health Services Academy, Islamabad. So we found out that it's around 0.2 per thousand. HIV is around 0.2 per thousand, which was the double when I said that it is 100% increase. So in 2010 versus 2020, the increase was almost 100%, and the death rate was also higher to multiple times, not just 100, maybe more than this. So the death rate by this HIV was, so there are two sources through which we collect this data. One is this through this biological behavior, and other is through our sentinel sites, as well as because it's a notifiable disease. Whenever we do, whenever we find a case, it is reported into the systems. Around 24,800 people are currently on HIV treatment, ART. We know the key population numbers as well. We know the total number of estimated HIV is around 166,000. And just imagine 166,000 HIV and AIDS cases in Pakistan, and only 24,000 are currently on treatment, which means a huge number of people are there. They are getting treatment or procedures, and they are spreading it like anything. So data is there. The issue is what to do with the prevention and further treating these cases and preventing it further spread. That is a bigger issue.
I actually have to disagree there, Dr. Khan, because we do have the IBBS, but obviously those are only in the key populations. And for the general population, yes, it's a notifiable disease, and once diagnosed, the infection does get notified. But there's a huge gap between testing and diagnosis, obviously. And as seen by multiple outbreaks that you highlighted, for example, the Larkana one, the ones in Punjab and other parts of the country, which it's basically showing that we are obviously not doing enough for testing and diagnosis. And that means that we don't have enough data to have a better understanding of what the prevalence is in our general population. So once we have, and obviously then the second drop in the cascade is obviously when people are diagnosed and they are not on treatment. But I think even with the first step, which is testing and diagnosis, we have a huge gap in the general population. We may have some data through the IBBS for our key populations, but I think we need to do better with our testing and diagnosis in general population, whether it happens through testing in pregnant women or it happens through testing at high-risk populations, for example, patients with TB or patients with hepatitis. But I think there's still a gap that we need to address.
Yeah, actually, it's very difficult to test everybody in a country of 220 million, but you are right. And prenatal consultations, there is a window of opportunity, pre-surgical, there's a window of opportunity, dental practices. So it is the health facilities which are there as a gatekeeper. So if the general population is coming in contact with the health provider, that there is an opportunity for screening, and that should be explored instead of going to a population-based screening, which I think won't be number one allowed in here, and number two, the cost will be very high. So we need to be opportunistic in screening, and you are right. One approach is to get maximum screening at the health facility.
And can I just add a couple of things?
Sure.
I agree with Dr. Hamad when he said the services provided at certain healthcare facilities are not up to any standard. I'll give you a tiny example. A patient I sent for hepatitis C PCR, it took them more than 2 months to get the result back. So that is the level. And this was only last year. Plus, there was one proposal that was given to the stakeholders that if say a population, if you're empowering the population and they identify a healthcare facility, be in private sector or public sector, if they have a helpline to call on that this facility is using used needles or reusing, or a particular physician is using, they said, we will create a helpline, but what happens after that? The mechanism doesn't exist to act for that kind of person who's creating so many cases. So I think the political will need to exist, and it has to be very, very firm and strong, and the processes have to be stringent before we can generate awareness. But what happens after that? What happens when we start reporting?
Absolutely. And definitely this conversation is probably very important and can go on for much longer than we have time for. But just in interest of time, I'm going to move to the second question in our chat box. And that question is, who is responsible to make this topic interesting in teaching hospitals and in colleges? And can I start with Soumya and Bushra, because as representatives of the two societies that we have on our panel today, how do you guys recommend we actually incorporate more in our institutions and teaching within medical colleges and otherwise?
So Soumya, please go first. If Soumya is online.
I think
I think she just dropped off. So
okay.
Please go ahead, Dr. Jamil.
Okay. So one thing is making this a mandatory part of curriculum, so that everyone gets a basic kind of teaching in the basic principles. The second is what we are using at the moment is identify practitioners who are interested and engage those who because they are interested or because they are being forced to look at HIV, just engage all those physicians and all those facilities and start talking to them. Show them some respect. That is another problem, because we cannot just approach anyone and start telling them, do this, do that. So the basic principle of our engagement is just listen to them. What are their issues? What are they doing? Because half of the things they are doing are correct. It's just minor modification in practices which will do the trick for most of the centers. So doing these sessions at a regular basis for those who are already in clinical practice is basically the first step which we are following, in addition to many other activities which we are engaged in, including looking for funding addressing infection prevention and control, especially focusing those areas which are hotspots of HIV in the country. So we know, so a multi-pronged kind of approach we are engaged in, and I cannot go into details of all that now, but mandatory undergraduate curriculum, and then just engaging everyone who is interested in HIV practice to participate in regular sessions and keep on updating their knowledge base and engage them in a discussion, address their questions.
Thank you. And it's 12:45, but I'll just take one more question. And that is a couple of people in the chat box, as well as, as part of our discussions, this has come up multiple times. And that is both the high rate of use of injections in Pakistan and also the unsafe injection practices in the country. And I was actually looking this up recently, and data from our latest demographic health survey indicate that about 9% of injections given in Pakistan are unsafe. And on an average, every person receives 4 injections per year. So we receive 4 injections. Everyone in Pakistan receives about 4 injections per year, every year for their life, which is much higher than most of the other countries across the globe. So what can we do? So there are existing policies, as mentioned, that hope to address the safety or address the unsafe use of injection practices. But what can we do to reduce the rate of injections in Pakistan? And maybe I'll start with Dr. Hina Javed and then open to others for comments.
Okay, the injection, the rate is 9.4 injections, 8.3 injections per person per year. It's the highest in the world. So roughly one person gets 8 or more injections. Even compared to the regional countries, the neighboring countries, the ratio is much lower in Bangladesh and India. And 94% of these injections are unnecessary. So if we get like 2 billion injections per year in Pakistan, only 75 million are used for vaccination. The remaining are for pain relief and like unnecessary conditions which can be treated with medications, the oral medications. How we can prevent it? Sorry, was that the question? I missed the other half.
Yeah, absolutely.
There are multiple strategies. It has to be, as Dr. Bushra said, multi-pronged approach. One single strategy will not work. You have to have a mechanism of reporting, as I stated earlier, and plus generating awareness, like we are generating awareness among school children about metabolic syndrome. All the major schools have asked parents to send them home cooked food rather than the packed snacks and stuff. So I think we can start at that level, at the grassroots level, and talking about it. Particularly the confidence need to come from the physician. The patient will not talk about it. So identify the high-risk population and find a way in a non-judgmental way, as Dr. Bushra said earlier. It has to be a non-judgmental way. Electronic medical records, they are very important because you don't want the handwritten prescription with, say, a diagnosis of an infectious disease, particularly STD or something, written on it to go to other places. Yeah, and bear in mind, we are dealing with a population where there's high rate of illiteracy. They are rural-based population, more than 50% of our population. So the approach has to be catered according to their needs. So we know what the needs are, and we just need to spread the message according to their level of education and then bring it to our level. And I think, yeah, that's mainly it.
Thank you.
I would like to intervene here.
Sure, please go ahead.
This is a classic example of when we say we have made a policy, so policies fail. It's a classic example of failure of a policy. Big so time. This fact has been known and highlighted, and the policy was made in 2010. So what has been done so far, it's visible. So whatever little has been done has absolutely failed in curtailing our problems. So somebody somewhere has to take it up and just pursue it and make sure that if you make a policy, it has to be followed. So a policy was made that single-use syringes will not be allowed to be reused. So how do you enforce that? And then there was an attempt to bring in a self-destructing syringes, but then you cannot use these self-destructing syringes in a hospital setting. So blanket decisions are not possible, and then policies fail if you don't take the ground realities into consideration. And then again, teaching and training and strengthening and building up networks of family physicians. So there is at least one trained physician, and people know about that trained physicians and start moving away from quacks and start going to that trained physician to get appropriate treatment. So strengthening family physicians.
Yeah, I think the reason for taking the extreme decision of AD syringes was because the behavior change can take many years, 50 years, and we have a race against time. I'm not kind of defending it, but I'm trying to find a logical reason to kind of incorporate that.
Yes, but even that failed. So we are failing actually.
Yeah.
So I think this is a good time to wrap our session and Q&A session for today. I do believe that it has to be a multi-pronged approach. It has to be policy, education, training, and also community awareness and education as well to be successful. Not just addressing it from one angle is simply not going to work. It has not worked in any country across the globe. Countries who have, who started seeing a high burden of HIV back in the 80s and 90s and have almost achieved epidemic control. And we are just, unfortunately starting to see an increase in Pakistan now. So we should definitely not think of it from the policy side or education side, but all of these different aspects of HIV prevention and control and take them all together. I'll hand over back to our moderator, Dr. Saima Abbas, and thank you everyone from my side.
Thank you everyone for a very robust discussion with lots of ideas. And I think we have material for more webinars, especially looking at the psychosocial issues. And what I'm realizing from this webinar is that injection safety practices, our failures are our best teachers. So we can take an example of failure and just cut it down. And as Khalida said, whether there is a knowledge gap, an attitude gap, or a practice gap, and I would add to that an accountability gap. That is, I think, at the end of the day, what saves the good organizations who have accountability. That's in the beginning, that's all you need. So we will bring, from the APPNA standpoint, we'll try to bring some information on that. And thank you very much, everyone. Have a good night, and thank you for being here. Assalamu alaikum.
Thank you very much, everyone, for joining, and Khuda Hafiz.
Allah.
Bye, guys.